Outcomes and strategies for utilization of brachial access and preloaded delivery systems during fenestrated and branched endovascular aortic repair. This is our disclosures. The advent of sterile sheaths has contributed to the decrease in the use of preloaded delivery systems and upper extremity access for fenestrated branch repairs. However, the use of brachial access and preloaded delivery system is still necessary in some cases. Brachial access exposure consists in a small incision in the axillary hairline for larger diameter sheaths, and a small incision in the antecubital crease for smaller diameter sheaths. Although access to brachial access may be achieved to the antecubital fossa, this has become less common given the high rate of complications. We recently reviewed the studies of outcomes of upper extremity access during fenestrated endovascular repair, making a compound showing that the stroke rate was 2.4%, intracranial hemorrhage was 0.1%, spinal cord ischemia was 1.2%, MI was 0.9%, and the third. So what is the purpose of the preloaded guide wires? Normally, this requires a femoral brachial through and through access, like it's showing in this case with the use of fiber optic reel shape. This allows to stabilize the endograft and advance into the aorta. Indications of the use of preloaded delivery systems are tortuous anatomy of the aorta of iliac vessels, in which the use of sterile sheaths to access target vessels may be difficult, patients with high risk of spinal cord ischemia, patients with small iliac vessels, patients with complex prior failed EVARs with short distance from the lower visceral vessel to the neobifurcations, patients with extensive thoracoabdominal aneurysms, in which often the target vessels are in a step caudal orientation. There is basic concept that is important to understand to differentiate the different types of preloaded delivery system. The first concept is the LEM, or length extended model, that basically is a Teflon blue tube that protects the cap. The second one The second system was the MPDS, or Modified Preloaded Delivery System. This didn't have a LEM, could have a wire from above requested. Normally involves only 2 vessels. There's no viper required. Include catheters. And the main device French is 22 French. Then the next generation was the TPLP, or thoracoabdominal preloaded low profile delivery system. This one has no LEM, 2 vessels from above, 2 vessels from below. There's a viper required. Use wires of 018, no preloaded catheters. The main device was 20 to 22 French, and is normally really helpful when you have viscerals coming from caudal orientation and you have renals in a cranial fashion. The next system is the TPDS, or thoracoabdominal preloaded delivery system. Always has LEM, no BiPOR, no catheters. The main device is 20 French, use wires of 014, and all 4 vessels are cannulated from above. So it's really helpful in big thoracoabdominal aneurysms to do sequential catheterization of target vessels. Here's an example of how we do it with the help of this new technology of fiber optic reel shape that we use in our center. Of the graph as it's showing in this figure. And then the latest generation of preloaded delivery system is the single wire, or TPTT. That stands for thoracoabdominal preloaded through and through single wire delivery system. Basically, it looks for simplicity. Has no LEM, no BiPOR, no catheters. The main device is 18 French, and then the access is only 1 vessel from above. The operator can remove the wire during the case and use transfemoral access. That is because the wire exits the proximal edge. So in summary, the PTS system has 2 wires that come from below. The modified preloaded system includes catheters. The TPLP system has 1 wire that goes from above and 1 or 2 wires that come from below. The TPDS system, all the wires normally has the 4 vessels come from above, and the single wire is only 1 wire that comes from above. So what are the outcomes of using preloaded delivery system versus standard grafts? Recently, the U.S. Aortic Consortium published a study comparing preloaded delivery system versus standard graft, and showing no inferiority in technical success and no inferiority in any of the major outcomes or mortality, and reassuring that preloaded delivery systems are feasible and safe. So the next question will be, what are the outcomes of all these types of preloaded delivery systems? So we did a retrospective single center study in Dallas based on our IDE between 2015 and 2022. We grouped the patients based on the preloaded delivery system in 6 groups, including a group for standard grafts. 306 patients were included. There was no difference in technical success. There was significant difference in radiation to the patient and radiation during the procedure, favoring the single wire preloaded delivery system, and the main sheet was less for the single wire with a main of 18 French compared to the other devices. There was no difference in technical success and mortality. The 30-day stroke rate was lower in the preloaded delivery systems. As a conclusion, upper extremity access is frequently used still. The current evidence suggests that open brachial access is safer. In the recent years, upper brachial access has become the preferred access site in order to avoid complications. The preloaded delivery systems have evolved. Single preloaded guide wires design represent the evolution looking for simplicity, lower profile, and versatility. The frequency of cerebrovascular events with upper extremity access is low, but clearly the evidence says that it's higher compared with transfemoral access. Therefore, transfemoral access is the preferred access unless anatomic characteristics indicate that upper extremity access is necessary. If you want to know more information about this, you can read our recent paper in Seminars of Vascular Surgery. Thank you so much.